Hello, good afternoon. Hello, good afternoon. Hello.
Hello, good afternoon.
Yeah, how are we doing?
Please, we're fine.
Okay, all right. So today is our first meeting online, and um, my name is Isha, and we'll be going through some topics in preparation for the professional exams and also your final end of year exams. So there are a couple of topics I'll be handling with you, and I'll be starting with cardiovascular. So under cardiovascular bit, my part is to handle the vascular aspect. So I'll be doing peripheral vascular disease, then venous thromboembolic diseases. So that will be my aspect for cardiovascular. Then we move to other systems. So I'm sure your coordinator has told you to read about peripheral vascular disease. I expect today's discussion to be interactive and engaging. So how we'll be going about the topics is that after every topic or discussion, we have some set of questions on that topic and we'll try our hands on them. And then whilst I'm talking, you should also be jotting down your points, the salient points and all that, because you wouldn't have any lecture notes or any slides afterwards. So make sure that you are very attentive. If you don't hear anything, let me know. If you have questions, you can always ask. Are we good? Can we proceed?
Yes, please.
Okay, all right. So we are talking about peripheral vascular disease. So when you look at the name, peripheral vascular disease, you are looking at the peripheral vessels. And these peripheral vessels are basically vessels that supply blood to all parts of the body other than the brain and the heart. So the vessels that supply blood to all parts of the body other than the brain and the heart. So when you look at the brain, the vessels that supply the brain are the cerebral vessels. And for the heart, the vessels that supply the heart are the coronary vessels. So any other vessel aside the ones that supply the heart and the brain will be considered as peripheral vessel. And basically for peripheral vascular disease, it's subdivided into two. When you look at the major vessels that supply the periphery, you have the arteries, you have the veins, you have the capillaries. The two major ones are the arteries and the veins. So based on this, you can have peripheral artery disease and you can have peripheral venous disease. So peripheral vascular disease is subdivided into two: peripheral artery disease and peripheral venous disease. So if it's affecting the arteries, we call it peripheral artery disease. If it's affecting the veins, we term it as peripheral venous disease. So we look at them one after the other. So in general, when you say peripheral vascular disease, it's basically an impediment of blood flow within the peripheral vascular system. So anything that is impeding blood flow within the peripheral vascular system is called peripheral vascular disease. And it can be an occlusion, it can be a damage to the vessel, it can be narrowing of the vessels, it can be a lot of things. So anything that is causing impediment of blood flow within the peripheral vascular system is called peripheral vascular disease. All right. So now that we've established the two types, we'll focus on peripheral artery disease. So you should first understand how the arteries operate. So basically, we know the functions of the arteries as they are supposed to supply oxygenated blood from the heart to all parts of the body, whereas the veins will do the inverse, will carry deoxygenated blood back to the heart. So in terms of the arteries, you well understand that there is no valves. So unlike veins where you have valves to prevent backflow of blood.
Please, can you begin with the second one? Hello, please, can you begin with the second one?
Yeah, so
Hello.
I was talking about... Hello? Hello? Hello, can you hear me?
Yes, please, Doc. We can hear you. We can hear you.
All right. So I was saying the arteries carry oxygenated blood to all parts of the body, whereas the veins do the opposite. So they carry deoxygenated blood back to the heart. Then in terms of the flow of blood, so arteries carry blood from the heart to all parts of the body. And because they are doing it towards gravity, there is no need for valves. So there are no valves within the arteries. Whereas the veins carry deoxygenated blood back to the heart and is against gravity, it's upwards. Because it's from the periphery, usually your legs, back to the heart, you know it's lower. So you need these valves to prevent backflow of blood back to the lower extremities. So that's another difference in terms of the arteries and the veins. Then in terms of blood flow within the arteries, blood flow is very fast. So arteries are usually termed fast-flowing vessels because blood flow within the arteries is usually fast. So they are referred to as fast-flowing vessels. Whereas veins carry blood slowly. So in terms of the rate of flow of blood is slow within the veins compared to the arteries. And it makes sense because veins are doing it against gravity. All right. So we are talking about the peripheral artery disease. And for peripheral artery disease, there are a lot of arteries that can be affected, but it's usually arteries that supply the lower extremities. So you have arteries supplying the upper extremities, arteries supplying the lower extremities. So peripheral artery disease, in terms of prevalence, usually would affect the lower extremities compared to the upper extremities. That is not to say you can have peripheral artery disease affecting the upper extremity. Just that it's more common in the lower extremities. The same for peripheral venous disease too. It usually also affects the lower extremities. So we will look at some of the risk factors that can predispose someone to getting peripheral artery disease. If you have any questions up to this point, you can ask before we proceed. All right. So, in terms of the causes, when you look at peripheral artery disease, there are two major causes. One of them is atherosclerosis, and the other is vasospasm. So these are the two major causes of peripheral artery disease. Is either you are having atherosclerosis blocking the arteries, or you have vasospasms where there is vasoconstriction of the arteries. For the risk factors, most of the risk factors are related to atherosclerosis. So we talk about atherosclerosis and its risk factors that can predispose you to peripheral artery disease. But what you should know is the two major causes are atherosclerosis, where there is formation of plaques within the arteries. So they block or they impede the flow of blood to the extremities. On the other hand, you could also have vasospasms, where there's constriction within the vessels, and that narrows the lumen, reducing blood flow to the extremities. So these are the two major causes. But the risk factors, we can have smoking. So smoking is one of the major risk factors that can predispose one to getting peripheral artery disease. Whatever you have a person who has smoked for a very long time, what happens is smoking or tobacco causes injury to the endothelial lining. Once there is injury to the endothelial lining, it exposes the underlying collagen. And from your lectures on atherosclerosis and all that, once there's damage to the endothelial lining, there's exposed collagen, and this exposed collagen serves as a very good substrate for a lot of inflammatory mediators. So you have these inflammatory mediators, interleukins, TNF-alpha, all aggregating at that site. You may also have fat deposition, usually known as fatty streaks, being formed at the site of injury. You can have platelet aggregation at the site of injury. Eventually, you can have a clot formation, and this clot is stabilized by a plaque. It's stabilized by this fibrous cap, and that is what is known as a plaque. And once you have a plaque there, you know that it can reduce the lumen of the artery, reducing blood flow within the arteries. So that's a brief explanation on atherosclerosis. And smoking can do injury to the endothelial lining. You can have patients with dyslipidemia. So patients with dyslipidemia, where there's abnormal lipid profile, you have high LDL, which is a bad cholesterol. You can have them being deposited within the lumen of the arteries, causing the formation of plaques and reducing blood flow to the extremities. Then diabetes. You know, diabetes usually moves with atherosclerosis. But some of the complications of diabetes, when you are looking at the macrovascular and microvascular, most of the macrovascular complications are atherosclerotic mediated. So your stroke, your MI, your peripheral vascular disease, all these are caused by atherosclerosis. So the excess sugar will be stored as fat. You can have a lot of deposition within the lumen of the arteries too, and that can lead to these atherosclerotic plaques. Then uncontrolled hypertension. So once the BP is very, very high, it can also do shear stress to the endothelial lining, exposing the endothelial lining. The underlying collagen will be exposed. You have inflammatory mediators aggregating at that site, your platelets, your fat. You can have eventually a clot that can be stabilized to form plaques. So all these are some of the risk factors of atherosclerosis that you should look out for. So once the person has peripheral artery disease, you don't just manage the peripheral artery disease. You look for the cause. If the cause is atherosclerosis mediated, then you should be looking out for the risk factors. So if the person is diabetic, you want to control the sugar. If the patient has dyslipidemia, you want to control your lipids. If the person has uncontrolled hypertension, you want to control the BP, and then smoking cessation programs for smokers and all that. So the management will be holistic. Just that you should always identify the risk factors that predispose the person to getting the peripheral artery disease. Any questions so far?
No, please.
Okay, all right. So that's for the risk factors. So the peripheral venous disease too, when you talk about peripheral venous disease, you are looking at any condition that will cause the peripheral venous congestion, meaning that anything that is impeding blood flow within the veins, that is not allowing the blood to return back to the heart. So there's impediment of venous return. And it could be an occlusion within the veins that is preventing that's preventing the flow of blood back to the heart. It could be a damage to the valves. It could be a damage to the walls of the veins. So all these can predispose someone to getting peripheral venous disease. So we look at some of the risk factors. So for peripheral venous disease, usually the cause is either an occlusion or damage to the valves or damage to the walls of the veins, or when you have overstretching of the veins. So all these are causes. So it's either an occlusion within the veins or damage to the vein valves and wall or overstretching of the veins. So these are the conditions that will predispose someone to getting peripheral venous disease. And commonly, the conditions that do occlusion within the veins, is your deep vein thrombosis. So you can either have deep vein thrombosis or superficial vein thrombosis. So if it's within the deep veins, it's called the deep vein thrombosis. If it's affecting the superficial veins, that's superficial venous thrombosis. So all these can do occlusion. And when there's occlusion, blood cannot flow as it's supposed to within the veins. Then you can have conditions that cause damage to the vein walls and valves. So a typical condition that can do that is varicose veins. So varicose veins, varicose veins will present as these rope-like structures or these rope-like vessels on the patient's leg. This is what we call varicose veins. So it appears as if a rope is coiled around the leg of the patient. So the rope-like structures or vessels that appear on the leg due to damage to the valves or the walls of the veins are known as varicose veins. So a typical condition that will cause damage to the vein valves and walls is varicose veins. Then You could also have chronic venous insufficiency. Basically, chronic venous insufficiency, what happens is there's overstretching of the veins. Because of the pressure within the veins, there's overstretching. The patient tends to have blood pooling within the legs. So the veins are not able to contract and relax as it's supposed to because of the overstretching within the veins. So chronic venous insufficiency can do that. So all these are possible causes you should look out for if someone has peripheral venous disease. So it could either be the person has an occlusion within the veins, which could be DVT, deep vein thrombosis, or superficial vein thrombosis. The person could have had damage to the vein walls or the valves. So if you look at the leg of the patient has varicose veins. You shouldn't be surprised that the patient is presenting with blood pooling at the legs. Then chronic venous insufficiency, where there's overstretching of the veins becomes incompetent. So they are not able to contract and relax as they are supposed to. So you can also have blood pooling at the lower extremities because of that. Any questions?
Doc, please, before asking if there will be, like, if you display any slides.
What was the question? Hello, what was the question?
Hello, yes, Doc, please, people are asking if you display, like, your slides. I know you won't give it to us, but, like, if you display any slides.
No, I don't have slides to display. As I said from the beginning, I teach without slides. And you are supposed to be very attentive. Make sure that you are jotting down your own notes. So if you are not able to get anything, you draw my attention so that I repeat that section for you. So for my approach, me and Dr. Takra, we teach without slides, so you should be able to get used to. Any other question?
Doc, please, you kept on saying blood pooling. What does that mean?
Hello, can you come with a question again?
Yes, Doc, please, you kept on saying blood pooling, that varicose veins and chronic venous insufficiency can cause blood pooling. That we can use blood pooling, something like that. Please, can you explain what that is?
So what I said was peripheral venous disease. The causes could either be occlusion within the veins or damage to the vein walls or the valves within the veins or overstretching of the vein walls. And I've given you instances where there can be occlusion within the veins. So for occlusion within the veins, you can have deep vein thrombosis or superficial vein thrombosis. So deep vein thrombosis, when there's occlusion within the deep veins, whereas superficial veins, when it's affecting the superficial veins, all these can cause occlusion within the veins. Then I also mentioned damage to the vein walls and also valves. So there are some conditions like varicose veins. Basically, varicose veins, you have damage to the walls. And because the walls are damaged, the walls become overstretched. And it appears as if you have a rope on the leg of the patient. So that's the varicose veins, causes damage to the valves and also the vein walls. Then I also mentioned overstretching of the veins, and that can be associated with chronic venous insufficiency, where there is a buildup of pressure within the veins. Because of this pressure, the vein becomes overstretched. And once they become overstretched, they become incompetent. They are not able to send blood back to the heart as they are supposed to. And that can cause blood pooling at the lower extremities. Is it clear?
Yes, please.
All right, so let's look at some risk factors that can predispose someone to getting peripheral venous disease. So, for peripheral venous disease, one of the major risk factor is obesity. So, obese patients are usually at risk of peripheral venous disease because of the pressure buildup within the lower extremities. There can be stretching of the walls, and the valves can be damaged. You can have pooling within the lower extremities. You could also have pregnancy. So pregnancy, because of the lower intra-abdominal pressure being generated from the fetus, you can have blood pooling at the lower extremities. So those of us who are doing ONG realize that a lot of the pregnant women have this rope-like structure on their legs. These varicose veins is very, very common in pregnant women because of the stretching and because of the pressure buildup within the veins. So you can have the veins appearing very distended on the legs. So that's varicose veins in pregnant women. So pregnancy is a risk factor to developing peripheral venous disease. Then advanced age. So as you age, the walls of your vessels become weak. So there can be weakness within the vein walls, and because of that, you can have blood pooling at the lower extremities. So usually 50 years and above, they are predisposed to getting peripheral venous disease. Then the female sex is also a risk factor to developing peripheral venous disease. This is because of the use of birth control pills, estrogen and all that can predispose you to getting peripheral venous disease. You can go through the DVT pathway. You know, these contraceptives can predispose you to getting DVT, and that can lead to peripheral venous disease. Aside that, the female sex itself is a risk factor because you said pregnancy. So if you are in the childbearing age, you can get pregnant and develop peripheral venous disease through that. So all these are some of the risk factors you should consider. Then people who sit or stand for long periods. So sitting or standing for long periods also can cause blood pooling at the lower extremities. And the more blood pool there, the more the veins would have to overwork. So eventually it can cause damage to the veins, leading to peripheral venous disease. All right, so any questions?
Sir, please, could you come again with the pregnancy?
So I was saying pregnancy, once you are pregnant, there's a buildup of pressure within the lower extremities because of the fetus. So that's lower abdominal pressure increases the pressure within the veins too, because the veins would have to overwork to be able to push blood from the lower extremities back to the heart. And the more the veins are overworking, the more you are predisposed to getting peripheral venous disease.
Okay, thank you.
Okay. Any other question? All right. So there are other conditions that can predispose you to getting peripheral artery or peripheral venous disease. Remember, for peripheral artery disease, I mentioned the main causes atherosclerosis. The other cause for peripheral venous disease was vasospasm. So a condition that can do vasospasm is Raynaud's disease. So Raynaud's disease. And basically what happens in Raynaud's disease is there is increased vasospasms within the arteries. And it's usually a trigger response. So there are certain triggers that can predispose you to getting Raynaud's. So usually exposure to very cold temperature. So if you are in a room and the place is very cold, that cold temperature can cause vasospasms to the extremities. And that can lead to Raynaud phenomenon. You could also have stress. So anything that can do stress can predispose you to getting Raynaud's. Because whenever you have stress, there's release of stress hormone, which is cortisol. That can lead to vasoconstriction. And once you have vasoconstriction to the extremities, you can have Raynaud disease. So peripheral artery disease is not always about occlusion. There may not be an occlusion. It could just be a vasospasm caused by cold temperatures, caused by stress. These usually tend to do Raynaud's disease. Then there is also another condition known as Berger's disease. So I'll type it in the chat box for you to see. So there's Berger's disease. Basically, this disease is associated with heavy smokers. So what happens is, the other name for Berger's disease is chronic obliterans. So I'll type it in the chat box too for you to see. So chronic obliterans angiitis. So that is the other name for Berger's disease. Basically, what happens is, for chronic smokers, we mentioned that smoking can cause damage to the endothelial lining within the vessels. Once there's damage, you can have fat deposition, you can have inflammatory mediators migrating to the site, you can have clot formation and all that. So this clot that has formed within the veins can obliterate or occlude the vessel, thereby reducing blood flow to the extremities. And it can also cause damage to the vessels itself. So that is how Berger's disease comes about. So it's associated with chronic smokers where there is damage to the vessels, leading to the formation of clots, and this can occlude or impede blood flow. And basically, this can affect both arteries and veins. So unlike the other ones, Berger's disease does both peripheral artery disease and peripheral venous disease. Any questions? All right. right, so if there are no questions, we'll move on. So we'll talk about the clinical presentation. So how peripheral artery disease presents is different from how peripheral venous disease presents. So to be able to differentiate these, you use this mnemonic vessel. So since we are talking about vessels, you use the mnemonic vessels. And the V stands for various position that alleviates pain within the leg. So the V stands for various position that alleviates pain within the legs. Then the E stands for explanation of the pain. So how the patient will describe the nature of the pain. So E for explanation of the pain. Then S for the skin color and temperature. So S for the skin color and temperature. The other S is for the strength of pulse. So the strength of the pulse you are feeling. So strength of pulse. Then the E for edema. So E for edema. And the L for the skin lesions or the lesions. So the lesions and their location. So this is how we will talk about the clinical presentation. And we use the vessel mnemonic to differentiate between peripheral artery disease and peripheral venous disease. Once you're able to establish the difference, you're able to manage the patient well, because all of them will present with pain in the leg and all that. So if you are not able to differentiate peripheral artery disease from peripheral venous disease, you may not be helping the patient. All right. So let's start with the V. The V is basically the various position that helps to alleviate the pain. So one of the common complaints will be that, oh, I feel pain in my leg. So whether the person has peripheral artery disease or peripheral venous disease, they are likely to feel pain. How the pain is relieved can tell you whether it's peripheral artery disease or peripheral venous disease. So for peripheral artery disease, what happens is we have two main positions. We have the elevation position and we have what we call the dependent position. So elevation position and the dependent position. So I assume the patient to be supine in bed. The person is lying flat in bed. So when you elevate your leg above your heart level, we say the person's leg is in elevation position. When the legs are below the heart level, that means the patient is in a dependent position. So these are the two positions we'll be talking about. Elevation position, when they elevate their legs above the heart level. Then dependent position, where the leg is below or dangled below the heart level. So for someone with peripheral artery disease, remember we said the two major causes is either atherosclerosis or vasospasm. So assume that there is atherosclerosis, which is blocking blood flow to the lower extremities. So the patient will feel pain. However, the moment the patient dangles the leg off the bed, so we said the patient is on the bed, so if the patient dangles the leg off the bed, that means it's below the heart level. Once it's below the heart level, the patient will have some relief from the pain. Because once you are below the heart level, then in a way you are helping with gravity, and that will help push blood to the lower extremities. Whereas when you elevate the leg above the heart level, once the leg is elevated, that means the heart is not able to pump the blood as it's supposed to the leg or the lower extremities. So in terms of perfusion to the lower extremities is reduced. But once you have reduced perfusion, there's ischemia, and ischemia, prolonged ischemia can lead to infarction and eventually can lead to gangrenous legs and all that. So the patient will feel pain because there's ischemia. And when there's ischemia, you know there's release of adenosine, just like how you have angina pain. Ischemia within the coronary vessels will cause release of adenosine that will stimulate the pain receptors for you to feel the pain. So it's the same way. So the equivalent of coronary artery disease, where you have reduced perfusion to the coronary vessels, here you have reduced perfusion to the lower extremities. And because you've further elevated the leg, the patient will feel pain more. But the moment you lower it below the heart level, the patient wouldn't feel the pain. Is it clear?
Sir, please, can you go over again?
So I was saying for peripheral artery disease, the issue is with either occlusion within the vessels or vasospasms within the vessel. So assuming the patient is lying flat on the bed or lying supine on the bed, if the patient has peripheral artery disease, because the patient is lying flat and there's also occlusion within the arteries, blood is not able to move to the lower extremities as it's supposed to. However, when you dangle the legs below the heart level, that means you are aiding with perfusion. And once you are aiding with perfusion, you can have reduced pain. However, for someone who has elevated the leg above the heart level, this is against gravity. And because it's against gravity, it's difficult for the blood to reach the lower extremities in the context of reduced perfusion from the occlusion. So if you've occluded a vessel and the person has also elevated the leg, it's very hard for blood to get to the extremities. So the pain worsens in the elevation position, but is relieved in the dependent position. Is that clear?
Yes, please. Thank you.
All right. Now let's look at peripheral venous disease. So still on the vein, the various positions that elevate or alleviate the pain. So for peripheral venous disease, the issue is the veins are not able to return blood back to the heart. And they are not able to do that because there's either an occlusion or damage to the vein walls or the valves or overstretching of the veins. So what happens is, if the person is feeling the pain and they decide to dangle their legs below the heart level, what this means is that the heart or the veins will find it difficult sending blood back to the heart, because now the leg has been dangled below the heart level and the veins are supposed to push blood against gravity. So because it's below the heart level, it's against gravity. So it will have to overwork to be able to send blood back to the heart. However, if the patient elevates their leg, what this means is that you are going to assist with venous return, because the veins are supposed to send blood back to the heart, but they are struggling. But because you've elevated the legs, it's going to help them push blood back to the heart. And that is one of the things that you should look out for. So for peripheral venous disease, the pain is relieved in the elevation position, but it's worsened in the dependent position. Any questions? So that is one of the things that can help you differentiate. So when the person comes to you at the pharmacy, they are suspecting peripheral venous or peripheral vascular, you tell the patient to raise their legs. If they raise their legs and the pain is reduced, that means it's helping with perfusion back to the heart. So the pain will be reduced. However, if the person tells you the pain is rather worsened when they are elevating their legs, that means it's doing it, the arteries are overworking and they are doing it against gravity. So that is why the pain is there. There's ischemia. However, when they dangle their legs below the heart level, it helps with perfusion, and the blood is able to be sent to the peripheries for perfusion. Any questions? All right, let's move on to the next letter, which is E. So E is explanation of the pain. So how the patient is describing the pain can tell you whether it's peripheral artery disease or peripheral venous. We mentioned that for peripheral artery, the arteries are not able to send blood to the extremities because of occlusion or vasospasms. And once you have ischemia will cause the release of adenosine. And this adenosine is able to stimulate the pain receptors to give you the pain. So because it's an issue with ischemia, and ischemia basically means reduced blood flow. When there's reduced blood flow, you also have reduced oxygen supply. So it's not just the blood flow, but there's also reduced oxygen supply. So in terms of the explanation of the pain, for peripheral artery disease, they usually describe it as a sharp pain. The pain is sharp because it's an issue with oxygen supply. So it's an oxygen deficit that is causing that sharp pain. Whereas for peripheral venous, it's rather blood that is not able to be sent back to the heart. So there's blood pooling at the lower extremities. So the description is that the pain is dull and the legs appear heavy. So there's heavy and dull, achy pain. Whereas for peripheral artery disease, it's a sharp pain. So that is also one way of differentiating. Then the next letter, which is S. So the S talks about the skin color and temperature. So for peripheral artery disease, we said there's reduced perfusion to the arteries. And because there's reduced perfusion to the arteries, you don't have enough blood, enough oxygen. So the temperature will be cold. So there's usually a cold temperature, unlike the peripheral venous, which is warm. So it's not an issue with blood and perfusion. It's rather an issue with blood returning back to the heart. So you have a lot of blood being pulled at the lower extremities. So it will make the legs heavy and dull. Then it will also make the temperature also warm. So for peripheral venous disease, the skin temperature is warm, whereas peripheral venous disease, the skin temperature is rather cold. Then, aside the skin temperature, the color of the skin. So, in terms of the appearance, you realize that the color for peripheral artery disease is usually bluish coloration, showing that there's cyanosis. There's reduced perfusion that is causing cyanosis. For peripheral venous disease, it's usually warm and the skin color is usually red or it may be dark, a little dark. So that is how the skin appears. And since for peripheral artery disease, there's reduced perfusion, there's reduced oxygen supply, realize that the skin is thin. So it's not getting enough blood and oxygen. So the skin is thin, is dry, and it's also scaly. So the appearance is a thin skin, it's also dry, and it's also scaly because you are not having enough perfusion. Then even when you look at the hairs, it's usually hairless or very little hair grow in those areas. That should tell you there's reduced perfusion and oxygen and nutrients supply are also reduced. For peripheral venous disease, in terms of the appearance, I said the skin may be red, it may be dark or have this brownish discoloration. Then in terms of the skin, because it's not an issue with perfusion, but rather pooling, the skin is very thick and also there's a tough skin. So it's thick and tough. Then you may also have enough hair on that area, unlike peripheral artery disease where it's hairless. But it's also usually warm to touch. So we said peripheral artery disease, the legs will be cold, but here it will be warm to touch. So that is how the skin color or the temperature will appear. Any questions? All right. Let's look at the other S. The other S is strength of pulse in the lower extremities. And basically here, you just want to check for pulse. And you know how we check for pulse. This time around, we are checking for pulse on the leg because this is the affected area. It's not just any pulse. So you try to check for pulse on the leg. And you realize that for peripheral artery disease, because there's reduced perfusion, there's reduced blood supply, when you try to check for pulse, the pulse may be absent or it may be a very weak pulse. So it's usually absent or very weak pulse. Whereas for peripheral venous disease, the pulse is usually present and is also normal. So peripheral venous disease is not an issue with perfusion to the lower extremities. So the pulse is usually strong and is also present. Whereas peripheral artery disease, because it's an issue with perfusion, the pulse is usually absent or is very weak. Then the next one is E. This E stands for edema. So the presence of edema. So for peripheral artery disease, because there is no blood pooling, you usually wouldn't expect edema in peripheral artery disease. Whereas for peripheral venous disease, because you have pooling of blood at the lower extremities, you can have so in terms of edema, you can have swelling or blood pooling at the lower extremity. So edema is usually present, but peripheral artery is because of reduced perfusion. So they will both present with leg pain. You go and check peripheral artery disease. There is no edema. Peripheral venous disease, there is edema. Then the next one is L. And the L here, we are looking at the lesions. So when you have peripheral artery disease or peripheral venous disease, and it's not managed, it can lead to formation of ulcers. So you can have ulcers on the leg from peripheral artery disease. So these are known as arterial ulcers. Whereas for peripheral venous disease, you could also have peripheral ulcers, peripheral venous ulcers. So these are the two ulcers. So peripheral artery ulcers and peripheral venous ulcers. So we said peripheral artery disease usually affects the extremities. So location of the ulcers are usually at the extremities for peripheral artery disease. So take note, the arteries are affected. So there is reduced perfusion to the extremities. So typically, if you get an ulcer in peripheral artery disease, you should be looking at the toes, around the ankle region. These are the areas you would have ulcers for peripheral artery disease. Whereas peripheral venous disease, the ulcers usually affect the middle part of the leg. So around the shin area, that is where you have ulcers developing for peripheral venous disease. And with the ulcers, for peripheral artery disease, the ulcers have very little drainage. So if there's fluid coming from the ulcers, it's very little for peripheral artery disease because there's reduced perfusion in the peripheral artery disease. So if there will be any drainage at all, it will be very little. Then in terms of the appearance, the ulcers are usually pale or light pink. So they are pale or light pink because they have reduced perfusion. You don't have a lot of blood flow to that extremity. So it's pale and light pink. Then the edges are usually round. So you usually would have round edges. So that's a description of the arterial ulcers. So take note that these are usually formed at the extremities. The toes, if it's the ankle, it will usually be at the lateral side of the ankle. So that is that for the arterial ulcers. The venous ulcers, here there's a lot of drainage because of the blood pooling at the lower extremities. You have a lot of drainage. Then, in terms of the appearance, it's deep pink or red. So, because of blood perfusion to that part, it's deep pink or red. Whereas, tremus, it's not like that. Whereas for venous ulcers, it's not like that. We said that one, there's a lot of drainage, it's deep pink or red in appearance, and the edges are usually irregular, unlike arterial ulcers where the edges are round. Okay. So any questions on the differences between peripheral artery disease and peripheral venous? So we've been able to talk about the clinical presentation, how it will be present or it will appear. And for peripheral artery disease, we've described how it appears. Peripheral venous disease, we've also described how it appears.
Hello, sir. Please, edges. What do you mean by edges?
So it's an ulcer. So if you have an ulcer, the edges of the ulcer. So the edges of the ulcer are round in arterial ulcers. Whereas for venous ulcers, the edges are irregular.
Yes, please. Thank you.
Okay. Any other question? All right. So that is how you're able to differentiate. So at a community level or even at the hospital, sometimes it's difficult to differentiate between peripheral artery disease or peripheral venous disease. But if you're able to go through this mnemonic, it helps you to differentiate. So peripheral artery disease, the pain worsens during the elevation position. And the pain is alleviated when you dangle your legs below the heart level, which is the dependent position. Then, in terms of the E, you are looking at the explanation of the pain. The pain is sharp, unlike peripheral venous, where the pain is heavy and dull. Then, for the S, which is the skin color, skin temperature, peripheral artery disease is usually cold because you have reduced perfusion. Then, in terms of the appearance, the hairs are usually absent or very little. Then the skin is thin, unlike peripheral venous where it's thick. Then, in terms of the strength of pulse, when you try to check for pulse in peripheral artery disease, it's usually absent or weak because you have reduced perfusion. Then in terms of E, which is edema, edema is absent usually in peripheral artery disease, but it may be present in peripheral venous because of blood pooling at the lower extremities. Then in terms of L, which is the location of the ulcer, it's usually at the extremities for peripheral artery disease, but in peripheral venous, it's usually around the medial part of the leg. So all these can be used to differentiate. All right. So after doing all this, if you want to further confirm patient has peripheral artery disease or peripheral venous disease, then there are certain investigations that you should do. So now we are moving on to talk about diagnosis. So how would you diagnose peripheral artery disease? And how would you diagnose peripheral venous disease and all that? So the diagnosis, for every diagnosis, the first thing we start with is history. So you should first take history to know whether the patient is likely to have peripheral artery disease or not. So the history, you want to find out the things that we've talked about in terms of the risk factors. Do you smoke? Do you have any chronic condition like diabetes, uncontrolled hypertension? Do you have dyslipidemia? Then you also want to establish, if it's peripheral venous disease, you want to establish whether the patient is pregnant. But pregnancy can do that. When you look at the legs, is there any varicose veins on the legs? Does the patient take contraceptives or is a person at high risk from maybe the fact that the person is a female and is also pregnant and all that, obesity, and even the age of the patient. Then you can look at the occupation. Per the occupation, does the person stand or sit for long? All these are things you should look out for. Then, aside that, the clinical presentation can also give you an idea. So, as I said, if the pain is relieved in the elevation position, likely to be peripheral venous. If it's rather worsened in the elevation position, rather likely to be peripheral artery disease. Whether there is edema on the leg, the appearance of ulcers, what's the location, how does it appear? Is it pale? Is it deep pink? Are the edges round or irregular? All these can give you an idea whether you are dealing with peripheral artery disease or peripheral venous disease. So aside the history, you can do clinical examination where the physician would want to examine the legs, want to check for presence of pulse, to see whether pulse is present or absent. Also want to check the temperature on the leg, whether it's cold or it's warm to touch. Then they want to check whether it's tender, not tender, whether it's swollen, are there any ulcers, what's the appearance of the ulcers and all that. So aside that, there is a bedside examination the doctor can also do. And this bedside examination, we'll call it the ABI index or the ankle brachial index. So ABI stands for ankle brachial index. And this is a simple test that can be done at the bedside. Basically, what the doctor will do is that the doctor will make the patient lie supine in bed. So you lie flat on bed, and the doctor tries to check the blood pressure within your arm and the blood pressure around your ankle. So they'll put a blood pressure cuff on your arm. So that is the brachial artery. Then around the ankle region. Basically, what we are trying to do is we want to check for blood pressure in the arm, then compare it to the leg. So this is a ratio of the blood pressure of the ankle divided by blood pressure at the arm. So ankle brachial index, blood pressure of the ankle divided by blood pressure of the arm. For the ankle brachial index, you know, when you check for blood pressure, you have a systolic BP and a diastolic BP. So if you are checking for ankle brachial index, you only use the systolic blood pressure. Because the systolic blood pressure is basically how the heart is pumping the blood. So you want to measure the pressure of the blood within the brachial artery and also the pressure within the ankle artery. So the systolic blood pressure of the ankle divided by the systolic blood pressure of the arm. So if you do this ratio and you get a value less than 0.9, if it's less than 0.9, that means the patient has peripheral artery disease. But if it's greater than 0.9, that means the patient does not have peripheral artery disease. So it's a simple test you can do. It's basically putting a blood pressure cuff on the arm and a blood pressure cuff on the leg. So you check the pressure within the arm and also the pressure within the legs. So if the systolic blood pressure of the arm is, let's say, 140, and the systolic blood pressure in the leg is 120, that means 120 divided by 140. The value you get, so if you do 120 divided by 140, you get 0.857. This value is less than 0.9. That tells you the patient has peripheral artery disease. So ankle brachial index less than 0.9 means patient has peripheral artery disease. If it's greater than 0.9, that means the patient does not have peripheral artery disease. Any questions? All right. So basically, that is how you perform the ankle brachial index. The systolic blood pressure of the ankle divided by the systolic blood pressure of the arm. And once you do that ratio and it's less than 0.9, means the patient has peripheral artery disease. If it's less than that, the patient doesn't have. If it's greater than 0.9, the patient doesn't have. If it's less than 0.9, the patient has peripheral artery disease. So even at a community pharmacy, if you are suspecting someone has peripheral artery disease, you can do that. So this is just for peripheral artery disease. We don't use it for peripheral venous. It's only for peripheral artery disease. However, if you want to confirm the patient has peripheral artery disease, then you want to do arterial Doppler of the leg. So you can do a Doppler ultrasound. And basically, the Doppler ultrasound is trying to check for flow of blood within the arteries. So when you put the probe on the leg and try to visualize the arteries, you realize that for peripheral artery disease, there's stenosis or there's narrowing within the arteries. It's either because of vasospasms or because of occlusion. We talked about the two major causes. It's either you have atherosclerotic plaques, which is narrowing the vessels, or you have vasospasms causing reduction in the lumen of the vessel. So this can be visualized from the Doppler ultrasound. So if you do an arterial Doppler of the leg, you'll be able to confirm the patient has peripheral artery disease. If it's peripheral venous disease too, you can also see it. When you try to put a probe there to visualize the veins, you also see either a clot. If it's DVT or SVT, you see a clot within the veins, or you can see damage to the valves. So the valves are not able to open and close as it's supposed to, or the walls are overstretched. So when there are overstretched walls, vein walls, you can also visualize it from the Doppler. So the Doppler is more like the confirmatory test for peripheral artery and for peripheral venous disease. Any questions?
Sir, please, could you repeat for the arterial Doppler sound again?
So the arterial Doppler, basically, you put a probe on the leg and you are trying to visualize the arteries. You want to see how blood is flowing within the arteries. So typically, the patient has peripheral artery disease. There's either an occlusion from atherosclerosis or there's vasospasms, which is causing vasoconstriction and reducing the lumen of the vessel. So when you try to do an arterial Doppler, you'll be able to see that these arteries are blocked by plaques or they are narrowed because of vasoconstriction. or if there's damage to the arteries and all that, you can see that from the arterial Doppler. So that is one thing that you can do to confirm peripheral artery disease.
So thank you.
Okay. Any other question? All right, so if there are no questions on the diagnosis, let's move on to the management. So the management of peripheral artery disease is holistic. So it's not just about managing the pain. You are going to manage the risk factors. You are going to manage the causes. The risk factors, some are modifiable, others are not modifiable. So the ones that are modifiable, you try to modify those risk factors. So that is how you manage peripheral artery disease. So your goals of management, you want to relieve the pain. You also want to manage the underlying cause. So if it's vasospasms, you want to manage the underlying cause. If it's atherosclerosis, you want to manage. Then the risk factors that are modifiable too, you also want to modify the risk factors. Then you also want to reduce complications. So you want to prevent complications associated with the condition. And as usual, you also want to reduce mortality and morbidity associated with the condition. And also you want to improve the quality of life of the patients. So all these are goals of treatment that you should consider. All right, so let's talk about how to manage the pain. So there are drugs that are used in managing the pain. And these drugs, one of them is cilostazol. So I'll type them in the chat box for you to see. So we have cilostazol. We also have pentoxifylline. So pentoxifylline. Then we also have naftifural oxalate. Naftifural oxalate. So these are the three medications that are used in managing the pain associated with peripheral artery disease. Cilostazol, pentoxifylline, and naftifural oxalate. So we'll talk about these medications one after the other. So we start with cilostazol. So basically, cilostazol, how it acts is basically a phosphodiesterase type 3 inhibitor. You know, you have a lot of phosphodiesterase inhibitors. So we have type 5, type 3, and all that. The focus here is phosphodiesterase type 3. So it's able to inhibit phosphodiesterase type 3. And basically, what phosphodiesterase does is that phosphodiesterase is supposed to metabolize certain metabolites or certain substances in the body. And one of them is cyclic AMP. So phosphodiesterase is supposed to break down cyclic AMP. So if you give cilostazole, what cilostazole will do is it will inhibit phosphodiesterase type 3, thereby preventing the breakdown of cyclic AMP. So if you are not breaking down cyclic AMP, that means cyclic AMP would accumulate. And basically what cyclic AMP does is, cyclic AMP causes the release of nitric oxide, and this causes vasodilatation. And this cyclic AMP also prevents platelet aggregation. So that is how cilostazole acts. It's basically going to inhibit phosphodiesterase type 3. And once phosphodiesterase type 3 is inhibited, it's going to prevent the breakdown of cyclic AMP. And cyclic AMP, if it's accumulating, will cause vasodilatation by causing the release of nitric oxide. And it's also going to prevent platelet aggregation. So that is how cilostazole acts. And this is helpful in peripheral artery disease because in peripheral artery disease, we said it's either an occlusion. And the occlusion can be a clot, it can be fat, it can be anything. So if cilostazole is preventing platelet aggregation, that means it's going to prevent clot formation from these platelets being aggregated. Then it also has vasodilatory effect. So it's going to open up the lumen of the arteries, and this will improve blood flow. Once blood flow is improved, that means there will be no ischemia and there will be no pain. What is causing the pain is ischemia causing the release of adenosine, and you're having a lot of pain. But once you're able to reduce platelet aggregation, you are reducing occlusion, and you are also able to cause vasodilatation and improve perfusion, you are going to reduce the pain in peripheral artery disease. So that's how cilostazole acts. And cilostazole usually takes time for you to see the benefits. So one of the counseling points is that once you put the patient on cilostazole, you should advise them that it may take up to about 3 months for you to have the beneficial effect of the drug. So they shouldn't be looking for an immediate response that, oh, they started cilostazole for about a week now. They are not having any improvement in pain. Usually, how you measure the response to cilostazole is pain-free walking distance. So when you have peripheral artery disease, what happens is when you are walking or you are running or utilizing the muscles of the lower extremities, they will require more oxygen, they will require more blood. But in the context of occlusion or vasospasms, they are not able to get that enough blood or enough perfusion. So you start to feel the pain. However, during rest, when you are not engaged in any activity like walking for long distance, running and all that, you may not feel the pain. This is what we call intermittent claudication. So intermittent claudication is when you feel the pain during activity or exertion of the extremities, but it's relieved during rest. Just like angina, you feel the pain during exertion and it's relieved during rest. It's the same for peripheral artery disease. So when there's an occlusion, it's not blocked the whole lumen. So there's little blood coming. So at rest, you may not feel the pain because of that little blood that is coming. But the moment you engage in strenuous activity, you are walking for a long distance, you realize that the muscles tend to utilize more oxygen and blood. And because they are using more and you don't have enough, that means you are going to have more pain during exertion and is relieved during rest. So, any questions so far? All right. There are no
Hello,
questions.
sir.
Hello.
Yeah, so I'd like to know if psilocybin can be used in angina patients.
You like to know whether psilocybin has done what?
Can be used in angina patients.
So it's selective for phosphodiesterase type 3, and we are looking at the vessels of the lower extremity, the peripheral vessels. So it's not used for angina. So angina, you are looking for something that will act on the coronary vessels. This one acts on the peripheral vessels. But it can be used for its antiplatelet effect. But if you are looking for pain relief, you don't want to go for that in angina because it's more selective for peripheral vessels.
Very good.
Any more questions? All right. So let's look at the dosing for psilocybin. So when you are giving psilocybin, you start with 100 milligram BD. So that is how you dose psilocybin. You give 100 milligram twice a day. The issue with psilocybin is that you should look out for patients with heart failure. If the patient has heart failure, usually the New York Heart Association class 3, class 4, they usually tend to have mortality when you give them psilocybin. So there's a black box warning about psilocybin in heart failure. And the black box warning is irrespective of the severity of the heart failure, whether it's class 1, class 2, class 3, class 4, we avoid psilocybin in patients with heart failure of any severity. And this is because phosphodiesterase type 3 inhibitors have been associated with decreased survival or mortality compared with placebo patients who had class 3, class 4. So class 3, class 4 heart failure patients who were given psilocybin compared to placebo had a higher mortality. And basically it wasn't psilocybin that was used. It was other phosphodiesterase type 3 inhibitors like milrinone. You know, milrinone is used in heart failure. It's also one of the phosphodiesterase type 3 inhibitors. So when they compared the use of phosphodiesterase type 3 inhibitors in patients with heart failure and placebo, they realized that the heart failure patients were dying more compared to the placebo. So because of that, if the patient has heart failure, irrespective of the severity of the heart failure, avoid the use of psilocybin. It's contraindicated. So you don't use psilocybin patients with comorbid heart failure. So let's take note of that. The other thing is, when you are giving psilocybin, you give it 30 minutes before meals or 2 hours after meals. So if you are giving oral silostazole, you give it 30 minutes before meals or 2 hours after meals. So this is because of interaction with food. So because of interactions with food, you want to give it 30 minutes before meals or 2 hours after meals. So all these are some of the counseling points that you should talk about when giving silostazole. And if you are combining silostazole with cytochrome 2C19 inhibitors, example, omeprazole. So if the patient is taking something like omeprazole, which is a cytochrome 2C19 inhibitor, you want the patient to reduce the dose of silostazole. So patients taking 2C19 inhibitors like omeprazole, erythromycin, or even 3A4 inhibitors, you want to reduce the dose of silostazole to 50 milligram BD. So instead of 100 milligram BD, you want to reduce to 50 milligram BD because these agents metabolize silostazole. So if we've inhibited cytochrome 2C19 and 3A4, which are the major agents or the major enzymes that metabolize silostazole, it means that you are going to have accumulation. And once you have accumulation, you can have side effects from the medications. So these are things that you should take note of when you are giving silostazole. Any questions? All right. So we talked about some counseling points. You know, silostazole, you should take it 30 minutes before meals or 2 hours. This is because when you take it with high fatty meals, it can increase the peak concentration by about 90% and also increase the area under the curve by 25%. And once you increase the peak concentration by 90% and area under the curve, which is the bioavailability, by 25%, you can increase the toxic effects of silostazole. So you take it 30 minutes before meals or 2 hours after meals. Then we also talked about the fact that it should be avoided in heart failure patients because of the increased risk of mortality when giving silostazole with heart failure. So if the patient has heart failure of any severity, there is high probability the patient may suffer mortality compared to placebo. Then we talked about the fact that it can interact with certain medication. If the patient is on cytochrome 2C19 inhibitors and cytochrome 3A4 inhibitors, you want to reduce the dose to 50 milligram BD so that the side effects are also reduced. Any questions?
Sir, please, could you repeat the parts with the fatty meals?
Yeah, so when you take silostazole with fatty meals, it can increase the peak concentration of the drug by 90%. And it can also increase the area under the curve, the AUC, area under the curve, which is also known as the bioavailability, by 25%. So because of that, you want to take it 30 minutes before meals or 2 hours after meals.
All right, thank you.
Okay. Any other question?
Please, can it be given to pregnant women?
Hello, come again with a question. Hello.
Please, can it be given to pregnant women?
Oh, okay. So usually you want to avoid pregnant women because of the risk of adverse effects. So animals, there is some toxicity when you give it to animals. So because of that, you want to avoid in pregnant women. However, it's not a contraindication. It's pregnancy category C. So once the benefits outweigh the risk, you can give it in a pregnant woman. But generally, if the patient would be able to cope with the pain or the condition, then you want to avoid silostazole. However, if there is no alternative, then you can still give silostazole. Just that you will just have to monitor for the risk associated with it. Okay, so let's look at the other medication. So let's look at pentoxifylline. So I told you that in terms of if you want to really assess whether silostazole is working, you'd have to give yourself about 3 months. And basically what we do is we measure what we call the pain-free walking distance. So pain-free walking distance is the distance the patient is able to walk without feeling pain in the leg. So for example, if the patient is able to walk from, say, campus, maybe from faculty to Tech Junction without feeling pain, that is the patient's pain-free walking distance. Then we have what we call maximal pain-free walking distance. So the limit to which the patient can walk before he starts feeling the pain. Maybe if he walks to Tech Junction, he doesn't feel pain. But the moment he proceeds to walk from Tech Junction to say Bomso, then he starts feeling the pain. So that is the patient's maximal pain-free walking distance. So that is how you assess the patient. So if previously the patient can't even walk up to Tech Junction and they will start feeling the pain right from the faculty end, that was the patient baseline. So after giving the patient silostazole, we expect that the patient is able to walk further, meaning that they should be able to walk to maybe Tech Junction or Bomso before they start feeling the pain. So silostazole is basically going to increase your pain-free walking distance. So that is how you are able to assess the efficacy of silostazole. All right, let's look at the other medication. So we could also have pentoxifylline. So pentoxifylline is also one of the medications that is used to manage the intermittent claudication. Pentoxifylline comes from the class of drugs methylxanthines. So these methylxanthines, we know we have caffeine, we have theophylline, all these are methylxanthines. So pentoxifylline is a methylxanthine. And basically, what pentoxifylline will do is that it's a rheologic modifier. When we say rheologic modifier, what this means is that it modifies the flow of blood. So rheology, when you talk about rheology, the flow of substances. So in your dispensing, you were learning rheology for flow of powders. Here we are looking at rheology in terms of blood flow within the arteries. So this drug is able to modify the rheology of blood. And how does it do it? So it has ability to reduce the viscosity of blood. And once it reduces the viscosity of blood, blood is able to move rapidly through the vessels. So if you reduce the viscosity, blood is able to move rapidly. Then it also has antiplatelet effects. That would also prevent platelet aggregation and also prevent clot formation within the arteries. Then it's also able to improve RBC deformability. What this means is that, the RBCs are biconcave. So the red blood cells, their biconcave nature allows them to meander through smaller vessels. So pentoxifylline helps to improve their ability to go through smaller vessels. So just like how hydroxyurea helps with RBC deformability when you have sickle cell. These sickled RBCs are very rigid. They are not able to move through the vessels, blocking the vessels and causing the vaso-occlusive crisis. So when you give hydroxyurea, it's going to increase the fetal hemoglobin and improve RBC deformability so that it can meander through smaller vessels. It's the same for pentoxifylline. Pentoxifylline is also able to improve RBC deformability. So all these are reasons why pentoxifylline is used for intermittent claudication in peripheral artery disease. So it's able to improve blood flow by reducing the viscosity. It's also able to improve blood flow by improving RBC deformability, and is also able to reduce platelet aggregation. So typically the dosing for pentoxifylline is 400 milligram TDS. So you do 400 milligram TDS for pentoxifylline. The issue with pentoxifylline is it's not as effective as cilostazol. So cilostazol is more effective compared to pentoxifylline. So pentoxifylline is not routinely recommended. Then, if the patient has hemorrhagic stroke, pentoxifylline is contraindicated. So because it's going to improve the flow of blood, also prevent platelet aggregation, it can also cause bleeding. So if the patient has hemorrhagic stroke, you want to avoid pentoxifylline. Then if the patient has allergies to caffeine and all the methyl like theophylline, they may also develop a cross reactivity to pentoxifylline. And in terms of the side effects too, you can have angina pain. You can also have headaches, which is very common. Nausea and vomiting are also common. You could also have constipation. All these are common side effects. So look out for. And pentoxifylline is also taken with meals. So the counseling point is to take pentoxifylline with meals. Unlike cilostazol, which is taken 30 minutes or 2 hours after meals. Any questions? All right. So that's that for pentoxiflin. Let's talk about the last drug, which is used for intermittent claudication, which is the naphtidrofural oxalate. So naphtidrofural oxalate, that one is not readily available in our setting. When you look at the cilostazol, that one is readily available. The pentoxiflin is also readily available, but the naphtidrofural is not readily available. So basically, what this drug is doing is that it's able to selectively block serotonin 5-HT2 receptors. So there are serotonin receptors, you know, they have 5-HT3, 5-HT2, 5-HT1. There are a lot of serotonin receptors. But this naphtidrofural oxalate selectively blocks 5-HT2 receptors, which are found on blood vessels and also on platelets. So once you block this 5-HT2, you know, serotonin ideally should bind to this 5-HT2 receptor to cause platelet aggregation. So if you block this 5-HT2 receptor, you are going to prevent platelet aggregation within the vessels. Then the other thing, the naphtidrofural oxalate will also be doing is that it's also going to improve oxygen supply to the vessels. So it improves blood flow to the vessels and oxygen supply. And all this does this by blocking the 5-HT2 receptor. So it's also going to help with ATP generation. Because you are utilizing the oxygen, you are going to produce more ATP, and ATP is needed by the muscles when you are doing any activity like walking or any strenuous physical activity like running and all that. So it improves glucose and oxygen utilization within the vessels to produce ATP, and that will serve as an energy source for the muscles. Now, all these are functions of the naphtidrofural oxalate. So when you look at the drugs that are used for intermittent claudication, this is the preferred agent. Naphtidrofural oxalate is the preferred. However, because it's not readily available, we usually use the other ones like cilostazol and pentoxiflin. But when you are looking at the preferred agent, and the preferred agent in terms of the walking distance, naphtidrofural oxalate improves your walking distance more compared to any of the other agents you've talked about, the cilostazol and the pentoxiflin. And in terms of the tolerability to it, has lesser side effects compared to the other ones. In terms of the dosing, you do 100 to 200 milligram TDS. So you do 100 to 200 milligram TDS. The side effects that you should be concerned about with this medication, from the name, naphtidrofural oxalate. So because of the oxalates, it can cause hyperoxaluria. You are having a lot of oxalate crystals. And these oxalate crystals can cause kidney stones. So it can block the nephrons, causing kidney stones. So you can have nephrolithiasis from naphtidrofural oxalate. because of the oxalate crystals. So there are a lot of kidney stones. You can have struvite, you can have cysteine, you can have uric acid, oxalate. But the type of kidney stones naftidrofural oxalate will cause is oxalate crystals kidney stones or nephrolithiasis. So you should advise the patient to take in a lot of water whilst taking this medication to prevent these oxalate crystals from accumulating in the kidneys. Any questions?
Yes, please. Sir, please, what's the I think I should say the onset of pain relief for the pentoxifylline and the naftidrofural oxalate.
So all of them, as I said, it will take about 12 weeks, which is 3 months, for you to start having the effects of the drug. So it may start after maybe about 2 to 4 weeks, but typically the maximal effect will be seen up to about 3 months. So if you want to see the actual benefits of the drug, you have to give it and wait up to 3 months. All right, any other question?
Yes,
Okay.
I have a question. While the patient is waiting, what can any other drug be given for cause of like an immediate relief?
Yeah, you can give other medications to help with pain relief. But the main medication that helps with pain relief are these three. So the others can be used as adjuncts and all that. But if you are looking for the actual pain relief from the intermittent claudication, then it's any of these three medications. Just that it takes time for you to have the effect of the drug. So you just have to counsel the patient, and if there's the need for other medications, you can add as adjuncts, but you don't stop these medications. Any other questions?
Plus, you didn't give the dose for the pentoxifylline.
So pentoxifylline, I said, is 400 milligram TDS. Cilostazol is 100 BD. Then naftidrofural oxalate is 100 to 200 TDS.
Thank you.
Okay. Any other questions?
Yes, please. Sir, please, are there any non-pharmacological approaches in managing these?
Yeah, so there are non-pharmacological management. So as I said, the management is holistic. So what we just talked about is managing the intermittent claudication. However, you are supposed to manage the risk factors and also the causes. So if the cause is atherosclerosis, you should find the risk factors that predispose the patient to getting atherosclerosis. So for peripheral artery disease, just like coronary artery disease, you do secondary prevention. So because the patient has developed atherosclerotic plaques within the arteries, they can develop future events too. So you want to put them on statins. So statins like atorvastatin, rosuvastatin to reduce the dyslipidemia. So if the risk factor is dyslipidemia causing the atherosclerosis, the statins will be helpful. Aside that, if the patient has normal lipids, you still have to put the patient on a statin if it's atherosclerosis. because of the other benefits of the statins, the pleiotropic effect of statins. So aside the lipid lowering effect, the statins have other benefits, which are the pleiotropic effect. And some of them is the antioxidant effect, the anti-inflammatory effect, is able to stabilize plaques. It also has antithrombotic effect. It also has anti-proliferative effect. And it also improves endothelial function by increased nitric oxide availability. So all these are pleiotropic effects of the statins: antioxidant, anti-inflammatory, antithrombotic, platelet or plaque stabilization, improves endothelial function by increased nitric oxide availability, and anti-proliferative effect. All these are beneficial, so you still give atorvastatin, usually the high-intensity statins. High intensity, you are looking around 40 to 80 milligrams of the statin. Then you also want to prevent platelets aggregation. So you also want to give your antiplatelets and also prevent future events. So either your aspirin or clopidogrel can also be given. Then, in terms of the risk factors too, if the risk factor is smoking, you also want to modify this risk factor. So you can do psychosocial counseling, which is a non-pharmacological way of managing smoking cessation. You can do psychosocial counseling. You can have a support group where people share how they were able to go through the process and how they were able to stop smoking. Then you can do pharmacological management like the nicotine replacement therapy. So you can do your nicotine patch, your nicotine gum, your nicotine lozenges. All these are nicotine replacement therapies. Then you can also do other medications that help with smoking cessation. So one of them is bupropion. So there's a drug known as bupropion that can be used, and there's also varenicline. So all these drugs, what they seek to do is they reduce your cravings to smoke, and they give you some euphoria effect. That is just like taking the nicotine or tobacco. So bupropion basically is a noradrenaline dopamine reuptake inhibitor. And basically, it reduces the reuptake of noradrenaline and dopamine, giving you that euphoria feeling, but it's not as if you are smoking. Then, varenicline also helps to reduce your cravings. It acts just like you taking nicotine. So it's able to stimulate the nicotinic receptors. So it's an agonist on the nicotinic receptors in the mesolimbic pathway of the brain. So the mesolimbic pathway is where dopamine acts on to give you that euphoria feeling. So it acts on the nicotinic receptor just like how nicotine would have done to give you the euphoria feeling without giving you the harmful effects of the nicotine. So all these can be given to reduce your cravings. And all these are part of the holistic management. So you identify the cause. If it's atherosclerosis, you manage. If it's diabetes, which is a risk factor, you want to optimize your glucose control. If it's uncontrolled hypertension, you also want to optimize the BP control. Any other questions? All right. So if it's vasospasms related, usually we want to avoid the triggers. So if it's cold temperature that is causing that, we want to avoid these very cold things. So patients can put on blankets, they can use gloves if maybe they are working in a place where there's always very cold temperature and can lead to peripheral artery disease from the vasospasms. Then they can take medications like calcium channel blockers. So these calcium channel blockers are able to cause vasodilatation within the peripheries. So one of the antihypertensives you want to avoid is beta blockers, because beta blockers can do vasoconstriction at the peripheries. So if the person has peripheral venous disease, you avoid beta blockers. You can give your calcium channel blockers. Any questions?
So, sir, please can you come again with the beta blockers?
So I said for beta blockers, you want to avoid in peripheral artery disease because they're able to cause peripheral vasoconstriction. So they block the beta receptors at the periphery, the beta 2, to cause vasoconstriction. You want to avoid beta blockers. You can give your calcium channel blockers that will do vasodilatation in the peripheries.
All right, thank you.
Any other questions? All right, so that's that for peripheral artery disease. For peripheral venous disease, the approach to management is identifying the cause of the peripheral venous disease. So I told you there can be occlusion from DVT or SVT. There can be damage to the vein walls or valves by varicose veins, or there can be overstretching of the veins by chronic venous insufficiency. So you manage the underlying cause. So if it's an occlusion, that means DVT, you can give your anticoagulants to manage the DVT, and that will help with the peripheral venous disease. If it's varicose veins, you can give your compression stockings. So you can wear compression stockings for varicose veins, or you can use certain medications. One of them is Daflon. The brand is Daflon or Flebodia. It contains diosmin, and diosmin is basically a phlebotropic agent. So it's going to cause constriction of the venous system, and that can help with the ability to push blood back to the heart. So it can help with varicose veins. Then, if it's chronic venous insufficiency, if it's Berger's disease, we manage as such. If the patient is smoking, presenting with Berger's disease, we want to stop smoking and all that.
Sir, please can you repeat the varicose veins again?
So that is how
Hello, sir. Please can you repeat the varicose veins again?
Yeah, so for varicose veins, you can use compression stockings, non-pharmacologically compression stockings. That would help with venous return. Or you can use pharmacological agents like diosmin. So diosmin is a flavonoid, and this diosmin is found in drugs like Flebodia, which is one of the brands on the market, or Daflon, which is also one of the brands on the market. So basically, it's going to cause constriction within the veins, and that's going to help with the venous return. So instead of blood pooling, it's able to increase the venous return by causing constriction within the veins.
Thank you.
Okay. Any other questions? All right. So if there are no other questions, this will be the end of the discussion for peripheral vascular disease. So we talked about how each of them presents, talked about the diagnosis bit, talked about the management. So the next thing we'll do is we'll
Sir,
solve
please.
questions. Hello?
Yes, sir, please. After the varicose veins, you were talking about the chronic insufficiency. Could you come again on that part?
Yeah, so chronic venous insufficiency, also you use the compression stockings. So you manage the underlying cause. The underlying cause is what you manage. So if it's DVT, your anticoagulants. If it's varicose veins, you can use your compression stockings. You can use your phlebotropic agents like diosmin. If it's chronic venous insufficiency, you can use compression stockings. At times, you may even do surgery. So surgery to correct the defect. So if there is maybe a clot in there, you want to do embolectomy to remove the clot, either thrombectomy or embolectomy to remove the thrombus or emboli. You can do peripheral artery bypass. So if you are not getting blood to a certain part of the body in the periphery, you can do a bypass so that the bypass would take blood away from the region affected and help perfuse the regions that are not getting the blood. Or you can put a stent within the vessel to open up the vessels, and that would also help with perfusion. So all these are non-pharmacological ways of managing peripheral artery disease.
Thank you, sir.
Okay. All right, so if there are no other questions, we'll end here. Hopefully our next meeting, we'll go through some questions on peripheral artery disease. If we are able to finish, we'll start with DVT. So our next topic will be venous thromboembolism, where we talk about DVT and P. So if there are no other questions, we'll end here. Have a good evening.